Dr. Haitham Nasser. He's going to speak about role of artificial intelligence in prostatic carcinoma localization and treatment. Of course, Professor Dr. Haitham is one of our eminent interventional radiologists in our unit, and I think we are going to gain a lot of benefit from his talk now.
في الأول أحب أقول إن أنا يعني أفتخر لانتمائي لوحدة الأشعة التداخلية عندنا في كلية الطب جامعة عين شمس، واللي كان ليا الشرف إن أنا أتعلم وأتربى على أيد أساتذتنا اللي كانوا السبب بعد فضل ربنا سبحانه وتعالى في أي حاجة أنا فيها وأعتقد زمايلي فيها، بداية من الدكتور أحمد الدري، الدكتور سامح عبد الوهاب، دكتور أسامة حتة، دكتور أحمد شاكر، دكتور محمد غريب. أحب أشكر دكتور سامح على المجهود الجبار في إدارة الوحدة، وأشكر أخويا وزميلي الكفاح الدكتور كريم عبد التواب. دكتور محمد جود لك في الفترة اللي جاية وربنا يوفق حضرتك إن شاء الله، وجود لك دكتور حميلي والدكتور أسعد. Thank you Dr. Paul for your comprehensive talk. I'm sorry I know you are late, so I'll try to be as fast as possible. So forgive me and feel free to keep any questions, record for any question and to answer it later on. Okay, we will discuss today the role of AI in cancer prostate localization and treatment. Let me tell you the whole study, the whole thing started when I met this guy, Professor Dr. Haitham, Professor of Medical Imaging AI in Norwegian University of Science and Technology in Berlin, 2018. We were having dinner together. That was the first time I knew the idea about having my camera pointed to the menu. I didn't know how to choose from the menu. It was written in German. So he suggested to use this method, point the camera to the menu. It started to translate it to English, so I can choose. Dr. Professor Haitham told me at this point, AI is coming, no way. You should not resist, but try to make maximum benefit from it. Okay, we'll start with the role of AI in fusion systems. What is fusion? Simply, fusion is making use of the recent technology, high resolution technology in MRI techniques in imaging of the prostate, and the accuracy of diagnosis or pointing out the suspicious area in the prostate that cannot be seen in the ultrasound. So we can fuse both images together using the AI, and we can target the lesion later on using the ultrasound guidance. In a simpler method, if this is the MRI images with the high resolution and the lesion noted, and this is the ultrasound where we cannot see the lesion, we can register points for the fusion, and then the fusion is done and we can target the lesion using the ultrasound to navigate inside the MRI after the fusion. Okay, this was the starting point of the AI. Earlier we should choose at least 3 points for the AI in the ultrasound and the MRI to register. Then we adjust the axis and you start to fuse in one plane, and then change the plane into the perpendicular plane to fuse another point or to register another point to fine adjustment of the fusion technique. Then we start to target the lesion. Later on, the AI became more advanced. It can recognize the volume of the prostate at itself in the MRI, take a volume of the prostate by the ultrasound, and then just adjust one point, and he can fuse volumes, okay? And then we do fine adjustment in other plane, and we start targeting. At this point, our team started to think how to make use of the AI. I remember Dr. Haitham, okay, we have AI, it can fuse ultrasound with MRI, how can I use this? So we started to use a third-party program to perform a volume of the prostate before the procedure of biopsy, and this is virtually, we have cuts with the same physics of the MRI study and blend it with the MRI study so that after fusion we can use this volume, okay? This is the volume we usually perform, planning, this is the sites of the needle, planning for the biopsy. This is the site of the suspicious lesions in the MRI study and our volume. And then and then we can do the fusion, putting the volume we've done in the MRI and on the ultrasound, so we can target the lesion precisely. And we'll see the needle going through the lesion. Why we are doing all this? Why we are using AI? Why we are trying to target the lesion precisely or accurately? I'll ask you a simple question, or if I give you these 3 darts and ask you what is the aim of each one of us, definitely all of us will select the right side image. All of us wants to take maximum cores from the lesion so that give more accurate diagnosis. Knowing that the accurate localization and targeting the lesion is the cornerstone in the treatment plan, okay? Looking toward the prostate and the biopsy procedure, we will see that random or systematic biopsy, we usually try to take 6 cores from each loop in a systematic manner. That we may miss in between the biopsies and even in the transition zone, which is the source of about 20-25% of the adenocarcinoma of the prostate. Looking forward for the normal anatomy of the MRI, this is the transition zone, and this is the peripheral zone. If we look at this patient, this is the planned volume for the needle site for the biopsy, and in this precise patient, we will see that this patient has 2 lesions, one in the transition zone and another one in the right peripheral zone, as we'll see now. So, if this patient goes for the traditional systematic biopsy, we will hit the lesion in the right peripheral zone and we will miss the lesion in the right transition zone. Knowing that the lesion in the right peripheral zone was Gleason score 3+3 and the one in the transition zone was 3+4. As we all know, 3+3 is a low risk for active surveillance and 3+4 is an intermediate risk for active treatment. So we shifted this patient from a patient that was not going to do anything to a patient that will have active treatment. Okay, the fusion early started with something called cognitive fusion, using mental power to do the fusion, and then changed into the software after the AI appeared. This is a short video showing how we do cognitive fusion. We see the images of the MRI, ultrasound. We do mental fusion using the anatomical landmarks in the prostate or anything, knowing that this is a slight calcification, urethra, bladder neck, to target our lesion. What is the problem with this technique? The problem with this technique is it needs a very highly expert operator knowing the anatomy, in addition to something called slicing effect in biopsying the prostate. What is the slicing effect? While we are taking the biopsy in the prostate, all of us thinks we are working in a TS manner, which is not true. We are not axial. At the base, we work axial, and as we go toward at the apex, we work axial. As we go to the base, we change from axial to oblique axial, then oblique coronal, then to coronal. If we look for this video, after fusion, we will see that after the fusion, the axial images are pixeled and the coronal images are more clear. That will show us that after the fusion, the coronal images was not so clear. So we are working more toward the coronal plane than the axial plane. So this will increase the fallacies in the bars using cognitive fusion. If we go back to the demo, we will see that while we are targeting a lesion in the middle of the prostate between the apex and base, first we will take a biopsy from the apex and biopsy from the lesion in the apex, and it will give us more than one core that is not supposed to be taken through the biopsy. That will give us a wrong impression about the burden of the tumor. Okay, do I work unsupervised? No, until now, the AI does not work unsupervised for 2 reasons. The first one, the AI depends on the site of the patient, the sensors, the device. If anything malaligned through the study, we should try the fusion from the start. And yet, it's still now, we have to ensure each, after each biopsy that we are aligned. Looking in this case, while we are taking the lesion, we will look for the ultrasound, we see the cyst, and the MRI, we see the cyst. We are aligned. We continue. Another landmark, we see the cyst and the cyst in the MRI in the same plane, so we are aligned. This is another patient using the plasma PET CT. In this patient, we were lucky that we have the lesion seen by ultrasound, so it is completely overlapped in the ultrasound with the lesion, with the volume we are done. This is another patient while we are taking the biopsy, and after taking the biopsy and registering site of the lesion, we ensure that we're aligned, the fusion was aligned. So looking for the cyst. There is many examples, but I will have to cut it short. What is the registration, and what is the GPS and smart navigation? We have done the 3D volume, put our our planned biopsies, our lesions. We make a 3D plan or 3D map for the patient, registering site of the biopsies and registering the suspicious lesion. Keeping in mind, we all know the difference between having an address and having a GPS point. A GPS point will take us to the same place using the shortest, fastest, and safest pathway, and keeping a record for our pathway. Having an address, we look for this one or this street. Both will take us eventually to our target, but keeping a record, having shortest, safest, and fastest pathway is usually better. And this is, and I don't know if you can see it, this is a smart navigation. It can guide us toward the lesion. We'll have our guide, this guide is green whenever we are in the pathway, blue and red according to our needle site to adjust the lesion. This is the final after the biopsy. We perform a 3D model before the biopsy and 3D model after the biopsy, registering actual site of the biopsies and the lesion to use it later on for any decision making. Value and the importance of targeted biopsy. Reduce number of biopsy procedure, increase diagnosis of clinically significant cancer prostate. As we have seen in the patient, we could miss him if we take the systematic biopsy. Diagnosis in time, 25 to 30% of cancer that cannot be sampled by traditional, as have seen in our patient, the transition zone lesion could be missed. Obtain better estimation of cancer extent and volume, and as we said before, we should not biopsy the lesion in the middle zone multiple times to give us a wrong idea about the burden of the tumor. Rule out suspicious MRI lesion and include the patient active surveillance. The benefit of the 3D model, change the MRI cuts into a model for biopsy for multiple regions. From multiple regions, we ensure that we are taking the biopsy. Register site of lesion for focal therapy or follow-up biopsy. Sometimes we put the patient on active surveillance. We need to go back to this lesion to ensure that the Gleason score remains as it is. And if we perform any intervention, either focal ablation or radiotherapy, you could go back for this lesion to ensure that the Gleason score of it remains the same. Ability to biopsy and planning before the procedure and focal therapy planning later on. Going forward, still working on how to make maximum benefit of the AI. We have done a 3D model, register site of the biopsy, register site of the lesion, took the biopsy, ensured the Gleason score of the patient, and the risk stratification of the patient. Going forward for the focal therapy, which is a middle ground between radical treatment and active surveillance. This is a study done by the AUA, American Institution of Urology, in 2021, stating that focal ablation proves effective and preserves erectile function and continence better than radical prostatectomy. This is the guidelines. We will see the difference between the guidelines in 2020 and 2023, changing from the focal ablation in a clinical trial with or a well-designed prospective cohort study into within a clinical trial or prospective registry. They are looking forward. It is coming more and more in the guidelines. looking to the publications regarding the focal ablation of the prostate, we'll see the number of studies rising from 1971 to 2020, and the number of publications using the laser ablation from 1980 to 2021. We usually start, as we said before, with the 3D modeling of the prostate and the lesion, site of the biopsies, and when the patient becomes positive, we start to do our planning. Our planning using regardless the type of energy we are using, we start to plan the lesion in the 3D model. We look for, in the two planes, we have a 3D model. We see the ablation zone. This is the ablation zone we are using by laser. We use laser. Okay. We start to see will we have pullbacks if the lesion is long enough, and we overlap the ablation zone to cover the whole lesion if we look forward for the lesion in two planes to ensure that it's completely ablated with a safety margin. This is a patient with an PET CT, with having plasma PET CT, having left posterolateral lesion as we see here. And this patient, this is the planning of the patient. This is the needle placed, and this is after the ablation, where we can see the coagulative necrosis of the prostate. And this is the follow-up of the patient. The ablated zone changes into a cystic area. Okay, the PSA drops. This is another patient with a lesion seen with a lesion less than 1 minute. A lesion seen anteriorly, which is traditionally it's not biopsied in the normal biopsy scheme, a systematic scheme. We took the volume, put our needles, ensured that there is a safety margin, and this is the follow-up of the patient, seeing that there is no conscious enhancement in the lesion at all after the ablation. Okay. Take-home message: no debate, AI infusion system are the future. Each of us should find the best way to benefit from them for the sake of better diagnosis and treatment for prostatic adenocarcinoma and anything else. Thank you all.
Thank you, Dr. Haitham. I would like to thank